Let's discuss about convergence excess esotropia, also called as convergence excess accommodative esotropia. So there are two types. Either the patient will have high AC by A ratio, or there's a hypoaccommodative type of convergence excess esotropia. The first type, high AC by A ratio, is more common. These patients will have high AC by A ratio more than 8:1. They may have the hypermetropia component present. But what is the classical feature is that they will have orthotropia for distance. With the glasses on, with the fully corrected glasses, they will have orthotropia for distance, but for the near, they will develop esotropia. So it's a kind of intermittent esotropia which is happening. And because it is intermittent, the BSV is also intermittent. When they're looking at distance, the BSV is present, but when you're looking at near, there is no binocular single vision. With the glasses on, this was the case. So what we can do here, because the AC by A ratio is high, you have to give a near add bifocals. And the bifocals will correct the near esotropia. Remember that give bifocals only when BSV is achieved. Means that you are giving bifocals to the patient. So now the patient should have straight eyes when he even looks the close object. And you can also check the BSV with the random dot stereogram or the stereo acuity test. So always the BSV should be attained, then go ahead with the bifocals. The treatment of choice for these patients is bifocal. You have to give an executive type of bifocal which should bisect the pupil and give the least near add. Now there are some controversies or some school of thoughts with the bifocal, that because you are giving a near add, so you are giving extra accommodative power to the lenses, so you are making the patient hypoaccommodative for the near. So some surgeons will prefer surgery over these bifocals, so not to make the patient hypoaccommodative for the near. The other option is you can give monovision contact lenses, where one eye will wear the contact lenses correcting for the distance vision, and the other eye will wear the contact lenses correcting for the near vision. So it is a monovision contact lenses. Another option which is available is myotics. Myotics will increase the amount of accommodation and hence they will decrease the esotropia for the near. They can be given for a short-term use in these patients. Now, what type of surgery you will do for a convergence excess esotropia? So first of all, give them full correction. So with the full correction, when you measure the distance, there is no angle. It is orthotropic eye. When you measure the near, you will find esotropia. So for this amount of esotropia, you have to give the correction, surgery part. Now what is happening? The distance thing is straight. Suppose you're correcting, you're doing a surgery for 30 prism diopters of esotropia, which was present with the glasses on for near. But so after surgery, what will happen? The eyes will be straight when the patient look at the near object. But what will happen with the distance thing? The distance was already straight without any surgery. So here there is a chance of overcorrection or patient going into exotropia for distance. For this we do prism adaptation test. And we analyze which patient can go for exotropia post-surgically and which patient may not go. So prism adaptation test will have a role here. So this is all about convergence excess esotropia. That part which is because of high AC by A ratio. The second part is because of hypoaccommodative variety. Here the near point of accommodation is remote. So the patient is not accommodating much. So excess convergence will happen in attempt to accommodate, and the patient will develop esotropia. The treatment of choice here is spectacles. Give full correction for distance and then give a near add. Remember, near add is always given only if when the BSV is attained. So that this will help to correct the hypoaccommodative variety of esotropia. So in summary, in convergence excess esotropia, you have to give bifocals because here the near distance esotropia is more than the far distance. At far, with the spectacles on, the patient is orthotropic, but you are having still ESO for the near. So you have to give bifocals. You have to give the least near add and executive bifocals. Second option is you can give myotics for short-term use or monovision contact lens. And finally, some may advise surgery. Surgery when we do, it is bimedial recession. Second option for surgery is fade-in operation. Here you are applying a posterior fixation suture to the extraocular muscle. So you are basically changing its effective insertion point. So this will cause not decrease in the angle of deviation, but this will weaken the action of the muscle. So when you apply posterior fixation suture to the medial rectus muscle, this muscle will get weakened. The weakening is seen when the patient looks in the direction of action of the muscle. So now here, when the medial rectus is weakened and the patient looks in the convergence phenomena happens, adducting, that time, when the adduction is going to happen, that time the muscle is weakened. So the action is not much. And hence, the esotropia will also decrease to some extent. So some surgeons will do a combined procedure. They will do medial rectus recession combined with the posterior fixation suture. And as far as the amblyopia part is concerned, now because the eyes are straight at distance, so they may not develop amblyopia. Okay, so that's all about convergence excess esotropia. Thank you.